stenosis was possible between two cuttings of the two arteries. He got a Nobel Prize for it. He's a French surgeon. But even before Norman Shumway and his colleagues were doing transplant, Demikov from Russia actually performed heart lung transplant in dogs. But most of the initial technique is all heterotopic because it was very difficult for explanting a heart and putting the heart in because cardiopulmonary bypass.
Venkat, can you a little bit louder, please? Because
Okay.
there's some comment coming that the volume is a bit low. Or you can put your mic closer.
Okay, I don't have a separate mic, but anyway, so cardiopulmonary bypass.
Yeah, that's better. Yeah.
So cardiopulmonary. So I needed to come close to that. That's what.
Yeah.
So once we had the cardiopulmonary bypass, that paved the way for people to advance in the technique of heart transplantation. Now, these two guys, they are basically, this man is the father, Norman Shumway. This is Dr. Lower. So that's why it's called, the technique is called the Shumway-Lower technique of heart transplantation, because this man Shumway on the left, spent his lifetime in basically, researching about transplantation. And it was really his great disappointment that he didn't do the first heart transplant because Christian Barnard went and did one, the first one. So the outcome of heart transplant remained very poor because rejection was the major problem. So the cyclosporin came in, and also there's a British surgeon called Philip Caves from Glasgow. He went and worked with Shumway in Stanford, in California, where Philip Caves developed the endomyocardial biopsy technique, and that biopsy forceps is called Caves bioptome. So that's why in ISHLT, any young surgeon who gets a very good research, he gets a Caves medal called Philip Caves medal. So it was actually Philip Caves, along with Norman Shumway, they came up with that endomyocardial biopsy technique to detect rejection. That led to an explosion in 1980s. We celebrated the 50th anniversary in 2017. So it's still only 53-year-old. There are some modification to the Shumway technique. The current technique is called the Widenshaw technique of heart transplantation, and that's what I'm going to, share with you. Now, I just would like to show these are the pioneers from Manchester: Abdul Dirania, Colin Campbell, and Ali Rahman were the three surgeons. They're all retired long ago. That was their anesthetist, cardiac anesthetist. And they started the program 33 years ago in Manchester. And we celebrated our 30th anniversary 3 years ago. So again, credit goes to them when they started the program. So I'm just going to go about the recipient selection. So this is from a chapter I wrote for a Cambridge University textbook. So it's just a simple outline of how we select a recipient. Obviously, patients are in quite bad heart failure. You're going to look at, is there any opportunity to do high-risk conventional cardiac surgery like coronary artery bypass graft or a valve surgery? If you cannot do, are they on an optimal medical therapy, which basically includes SC inhibitors, and beta blockers? Do they need a cardiac resynchronization therapy? Do they need an ICD? Then you have to make sure there are no major contraindication, especially they're not taking a lot of drugs and alcohol. We need to make sure they are compliant. And once you make sure that there is no other option available, they are on despite full medical therapy, they are still struggling, and then you go in and do an assessment for a transplant, because you have to do certain specific transplant assessment tests, and they have to fulfill before you put them on transplant list, because this is a gift of life. It's a health ration. Somebody has to die to donate a heart. So you need to be able to select an appropriate recipient who is going to get the best benefit out of this operation. You don't want to transplant someone who's going to not make the best use of that donated organ. So we normally look at patients with heart failure, and we just look at what is their functional capacity on the cardiopulmonary exercise test. Now, VO2 max is a very widely used. Everyone in Manchester, we have what is called as a one-stop clinic. The patient comes in the morning, they have an echocardiogram, and they'll have a VO2 max cardiopulmonary exercise test, and they'll have a BNP measured. And then they go and see the physician. So the physician will have objective evidence with the echo finding VO2 max and BNP level. And then you can look at, does the patient need to come in for an inpatient assessment so that you can do right heart catheter, CT scan, and other tests. So now, why VO2 max 14? Now, it's very interesting. Mancini and his colleagues in 1980s, they looked at patients who are not eligible for transplant. So they did, and also eligible for transplant, and they did VO2 max on them. And he had a group of patients who are eligible, who are not eligible, and those who have VO2 max of more than 14. And what he found was the people who have VO2 max less than 14, who are not eligible for transplant, they went home on medical therapy, but their outcome, their 1 year survival was only 10%. So it means if someone's going to die, the chance of dying is very high than the risk of the operation, then you put them for an operation. So that means if someone's got a VO2 max less than 14, if they are eligible for transplant, that means they should be listed because their 1 year survival is bleak. Those who have more than 14, their 1 year survival was actually 80%. So that is the background behind the 14, but the number 14 is arbitrary. So what do you do if you are a young patient? Because sometimes young patients will have a VO2 max of 90. But that's when you need to look at what is their actual predictive value, because they are so fit, they will do CPEX exercise well. So you have to make sure, is it less than 50% predicted? Now, Mancini's study was done prior to the beta blocker era. So that means when the beta blocker came in, patients started doing even better, even if those who had less than 14. So the arbitrary cutoff point had to be changed. So now, if somebody is on a full dose of beta blocker, if their VO2 max is less than 12, 10 to 12, then they are a high risk. If somebody is on beta blocker and their VO2 max is 14, they don't fall into a high risk group. But you don't look at one parameter, you look at multiple parameters. So recurrent admission, that means they are not doing well on medical therapy. We do transplant some patients who have no graftable targets. The ventricular function may be good, but they have intractable angina and ischemia. Recurrent arrhythmia is also an indication, because if you put them on inotropes, they'll get more VTs and no ablation possible. Now, there are a lot of contraindication because it's a gift of life. You don't want to transplant someone with an active HIV, hepatitis B, bad peripheral vascular disease, CVA, poorly controlled diabetes, bad lung disease, neoplasm, bad kidney. Now, GFR less than 40 is an absolute contraindication, because what you don't want is to give them a new heart and then end up with a kidney failure and they end up in dialysis. It's a dreadful quality of life. So we shouldn't do that. So recent PE is a problem. Anyone with a severe pulmonary hypertension, which is systolic more than 60, is an absolute contraindication. And transpulmonary gradient. Now, transpulmonary gradient is mean pulmonary artery pressure minus pulmonary artery wedge pressure. That gradient is more than 15, we will be concerned. Sometimes 15, 16, we do put them on some milrinone and see whether it's reactive, so that we can give them iloprost and maybe inhale nitric oxide, and hopefully the right ventricle might struggle in the new heart. But if you have a combination of PVR of more than 5, the wedge of 15, 16, 17, probably better not to transplant them. You may have to do a VAD on them, left ventricular assist device on them. Morbid obesity is a problem. We don't want to transplant them. Age is a relative cutoff. But again, if you have lots of donors, then you can do slightly older recipients as well. Now, I did explain about the VO2 max in my the previous slide, but not normally what we do is that we do a 6-minute shuttle test, but it's a simple tool, but we want to look at how many meters they walk, whether they desaturate, and what happens response. But we normally look at the CPEX, which everybody gets, unless the patient is very unwell on inotrope, then you can't put them on cardiopulmonary exercise test. The other problem with CPEX is, if a patient has got bad arthritis, how could you make them, walk in a treadmill? They won't be able to do. So again, some patients, it may not be possible. There's also some issue with the subnormal exercise test. For example, they may not have achieved the anaerobic threshold. So they might have done, say, 10, 15, 20 minutes. They might have reached up to 60, 70%, but then due to joint pain, they stop. But that is not actually, then the VO2 max will say 9, but that may not be the right test. So that's why you need to look at whether they've achieved the anaerobic threshold or not. But again, it is a very useful tool. We do it for all of our patients. And as I said, we have the one-stop clinic where we have capacity to do. We have 2 advanced heart failure clinic a week. So we probably see around 10 to 12 patients we can do this sort of assessment. Then we bring the patient in for an inpatient assessment. We normally bring patients on a Monday and they go home Wednesday. So they come in, they have already been to a clinic, seen a heart failure specialist, BNP done, cardiopulmonary exercise test done. They come, they are clocked in, seen by the coordinator. We ask them to be seen by a dietitian to make sure they understand the dietary input. We make sure the social care person looks at them, make sure there is no psychosocial issue. The psychologist see the patient to make sure they understand what they're embarking on. And then they do a CT scan of the chest so that we make sure we rule out any small lung cancer or small unknown malignancy. We do a full body CT scan, head, chest, and abdomen. And then we do all the blood results. They have a lung function test, and then they have a right heart catheter. So the patient coming on Monday will have the right heart catheter on Tuesday, so that on Wednesday, they are seen by a consultant surgeon with all the information, and then the patient is discharged home, and then we discuss the patient on our assessment meeting on the Friday, and then we make a plan whether to list or not list. So the right heart catheter, now it's an invasive procedure, but it gives us an important finding of what their pulmonary artery pressure is, what their pulmonary vascular resistance is, what's the transpulmonary gradient is. We also look at the PA saturation. We also calculate the cardiac output, cardiac index, because to calculate PVR, you need cardiac output, because TPG divided by cardiac output is the PVR, isn't it? So you need that. So we can calculate the PA systolic, diastolic, mean PA, wedge. So mean PA minus wedge is the TPG. TPG divided by cardiac output is PVR. And we also calculate saturation. We also do cardiac output through fixed principle, so that you calculate sats from the RA, PA, RV, iota, and then basically we calculate the fixed principle cardiac output, so that we have a full information about the recipient before we decide whether to list somebody or not. Now, once we decided that the patient is in a high-risk group, we also use a heart failure survival score. We don't use the Seattle heart failure model. The aim is that you want to basically look at their risk of dying within the 1 to 2 years with all the information you have. And if they are a high-risk candidate, they are better listed. Sometimes even if they are marginal, but if they are frequently getting admitted and if they have no other VAD option, then you may have to consider them. So it's just sort of a experience and a multidisciplinary team decision to put them on the list. Once you have the list, then you have a donor offer in the night. Then you basically have to go through an ABO compatibility, meaning, same like blood transfusion. O is an universal donor, AB is an universal recipient. So that means a blood group A recipient can have A and O. AB can have everything. So that's how it works. So we look at the height and weight of the donor to the recipient matching. Normally, we tend not to stretch, because we don't want to undersize a donor to the recipient. So height and weight both are looked at, but we go more of a height But we also don't want more than 30 kilogram, 20 kilogram weight difference. So you just have to look at it balance. In general, a female heart in a male, it should be a matched size or slightly overmatched. So you have a 172 centimeter male recipient and you have a 177 centimeter female donor, that's good. If you have a 178 centimeter male and you have a 162 female PGD, it will not work, it will struggle. So you better not take the risk. So if you have to have now in general, we don't want to give a old heart to a very young recipient unless it's really sick, dying, and you need to give him a heart because they will develop, this heart needs to work for a long time, vasculopathy is a problem. So we also have to look at the status, urgent, elective, that sort of recipient. And we also look at the pulmonary profile, because to transplant someone with a borderline TPG PVR, you would better have a good male heart because you don't want right heart failure. So again, it's not a, there is an app available. I don't know whether it's available. Papworth Hospital has actually devised it based on I think UNOS's data, and that app is available to download, and people can actually, I don't know whether it's available in India, but if it's available, it's very useful because it will give you, what is the amount of mismatch, and if it'll say green, amber, or red. If it's red, means it's better don't do it. So other things is the patient got a VAD explant, previous cardiac surgery. So all those things have to be taken into consideration. And then the donor team goes, donor management. Now I spent, as Murthy mentioned in his opening remarks, and I spent some time in retrieval because my research was on donor management, and most of my paper published are still, it's available free because they are landmark papers. And this is what we did. If in a donor, if the mean pressure is very high, we actively accept a lowish 65 to 70 mean. We reduce all these infusions and we wean the noradrenaline. We always gave vasopressin to reduce the diabetes insipidus in the donor, and we put a Swan-Ganz. We make sure the CVP is 12, wedge is 12 with a good cardiac index. We never started dopamine, but if at all you want, you can accept a less than 5 mg of dopamine. But again, I think it's a old criteria by Wielden et al. From Papworth. But again, if you don't want any inotropes, and if you have good filling pressure, good cardiac index, then you open the chest, no coronary artery disease. We do a TOE now. Our retrieval team takes a TOE machine. So we put the TOE probe in the donor. We take some measurements, and the video clip is sent to us through WhatsApp. I can look at the TOE images and then the cardiac index, and then a video clip of the heart will be sent. And then if all looks good, then it's a green signal to go for the transplant operation. So I'm going to talk about the Withenshot technique, which is basically a modification of the Shumway-Lowers biatrial technique, because currently we all do bi-cable technique. That's what everybody should do, because Withenshot published a lot about the benefits of bi-cable against the biatrial technique. But in certain condition, you may have to do biatrial technique. So it's nice to know that technique. If somebody has got a left SVC and you don't want to do complex reconstruction, and you want to keep the coronary sinus intact, and you want to do a biatrial technique, you may have to do, keep the coronary sinus of the recipient's heart, then you may have to have that technique. So it's nice to know, but I'll cover both the techniques. So we published about bi-cable Withenshot technique. So the thing about what we do, very good coordination is important because the ischemic time should be reduced. So we keep an 1 hour for a straightforward explant in a virgin chest. That means an hour before the heart arrives, we should be starting the operation, so that by the time the heart arrives, we have opened, we've gone on bypass, we've explanted the heart, and we are ready, so that as soon as the box comes in, I'm ready to open, start stitching the heart. If it's a complex pad, we spend 2.5 hours because it's a reduced anatomy. You have to dissect. You want to dissect before you give heparin, and you want to make sure that you don't get into. You also don't want too long a bypass time before the heart arrives. Most of the patients have ICDs, so you have to make sure the ICD is switched off because you don't want it to be shocking with the diathermy. And we try to do a fixed pacing with 90 to 100. We put a 5 or a 7 lumen CVP line. We do a PA catheter, put a TOE probe. We start some inotropes, ready to go on, and then catheter. And then we always have the groin available, but we'll have a groin arterial line, and we also put a venous sheath in the right femoral arch vein, because if a patient needs ECMO post-surgery, we would like to make it into a peripheral ECMO so that we don't have to open the chest for the patient. So a sheath in the right femoral vein and a femoral arterial line. If you need a balloon pump, it's there. So we always have that. And we don't give RATG infusion in theater, but I'll come to immunosuppression separately. So the cardiectomy, so once you go on bypass, once you know you are on time, so we always use a Medtronic arterial line in the aorta, and then 2 right angle pipes in the cava, caval snare. We use carbon dioxide insufflation. Then when it's 20 minutes for the heart to arrive, we clamp and we start the explant. So I've got a video here. Let's see whether it works.
So it's aortic pipe, IVC, cable snares, all in. We are on bypass now. Okay, fine. So we need to start cutting the heart out now.
So that's a patient who's now just on bypass, and I'm about to start cutting. So the aim in a cardiectomy is, the way I do it is to cut the heart out like a biatrial technique, so that you have large RA and LA cuff. Then you refashion the cable cup separately so that you keep as much of recipient heart tissue left, so that when the donor heart comes in, anastomosis is easy. So that is basically the important trick here. Now, okay, I'll show you the video here. So can you, the video okay? Yeah, video coming all right?
Video is coming all right. Yeah.
SVC, IVC. SVC is now snared. Now, with the help of the umbilical tape, the aorta is cross-clamped. Afterwards, IVC will be snared.
Is the commentary okay here, or shall I talk?
Incision is made.
No, the video looks good.
Body of the right atrium. Suckers in place. Incision is carried upwards towards the right atrial appendage. Inferiorly, incision is carried over close to the AV groove, leaving adequate cuff. Here the IVC, the aim is towards the coronary sinus, which you can see, even though the heart is clamped, still it's blood coming through it. Now, the pacing wires inside the right atrium have to be pulled completely and cut flush with the SVC. Then the remainder of the SVC into the right atrium to the roof is divided. I'm using a sharp knife. The fossa ovalis is tapped. The left atrium is entered. At this point, the suckers are placed. Then I actually use a diathermy to divide the intraocular septum towards the roof of the left atrium. The aim
Is the heart beating or is it cardio bleach for ease of
No, I
extraction?
don't. Okay, I don't bleach. I don't bleach it. It's just beating.
Okay,
It's
okay.
just cross clamp, but it's still beating. It's
Okay.
unnecessary to bleach. Yeah.
very close. Just
We spend about 3 minutes of bleach here just so that it doesn't beat and get in the way. You know, it's much more easier without the heart beating.
No, it's okay. Most of the time when the heart is taken out, it's still beating. No, I don't wait. I don't do it. Yeah. Yeah.
What we find problem is when there is an AICD put in, and when you please the heart, it starts giving us a lot of shock. So,
That's why
what
I did say that you should switch off the ICD and before you start the operation. I did say that. So anyway, okay. Oops.
Boot completely and cut flush with SBC.
Sorry, something
The
happened.
remainder of
Hey,
this
it went back.
to the right atrium.
Sorry.
The groove is divided. I'm using a sharp knife for survival.
Something has happened. Okay. Oh. So, okay, so I cut I don't know what happened. Can I, okay, I'll go back, then come back here. So I've cut the aorta and cutting the PA.
The pulmonary artery is now divided. I'm using Roberts. The assistant also uses the forceps to the atrial appendage, which is there.
Dr. Venkat, you can give your commentary also because
Yeah,
that audio
So,
is not very.
okay, what I do is once I cut the aorta on PA, I basically, use a diathermy to cut very close to the left atrial appendage. You can see the pulmonary veins are clear, well away, as much. So I go to the base of the appendage and basically start to go towards the mitral annulus. At this point, I put my finger underneath the heart into the left atrium and splay my fingers, and I cut in between. I take the coronary sinus with the heart. I don't open and ungroove the coronary sinus because I have to make sure the enough left atrium is left, but you can see the coronary sinus is there, but I'm just basically putting my finger in, and then I basically cut the heart completely off.
Coronary sinus with the heart, as you can see there.
That's a coronary sinus. I'm just taking it with the heart.
Is kept as I heading towards the coronary sinus now on the left atrium. Position and then use a diathermy to completely divide the heart, leaving the left atrial cuff, the right atrial cuff, as you can see, this being complete.
So now I'm going to cut the heart off with leaving the left atrial cuff and the right atrial cuff. Don't know why this is getting stuck. Murthy, I don't know what happened there. So
Maybe, like last time, you can go and restart at the
yeah. I need to, yeah. So I'm sorry.
Yeah, that's fine.
The whole thing is frozen. My screen is off. Okay, so I need to find. Let me. Mac.
Try escape button.
You can stop sharing the screen, then restart.
The problem is that even my mouse is now gone. Even that arrow mark is gone. I cannot see.
Your video is playing.
So God, I don't know what happened. Okay, I'm doing the escape screen, but
Yes.
Your mouse just briefly came on. Yeah.
it.
Yeah, your mouse just came on.
Okay. Let me. Okay. I'm very sorry, guys. I don't know what happened there. Shall I just stop share? Everybody, how can I do this? Pause.
Yeah.
Okay.
Okay. Yeah, now, we're seeing you on the video, and I think
Okay.
probably we'll be able to hear
Okay,
you.
so I need to go back. So
Go
my,
back to your presentation and share screen.
yeah. Michael. Murthy, shall I need to probably completely shut this down and restart. Sorry.
You log off and come back in again.
Yeah, 2 minutes, 1 minute. Sorry about that.
We'll wait, no problem.
Sure, take your time. Dr. Sundar,
Yeah,
sir,
sure.
you and Dr. Murthy can take over and
Dr. Sundar can describe his technique.
yeah, you can share Indian technique.
Plantation, basically.
Yeah, very much what Venkat has been saying. We follow the same thing, except we have a close communication between the donor and the recipient team. And as we said, we allocate about an hour for a straightforward, a virgin chest, and probably 2 to 3 hours. It is going to previous coronary, previous cardiac surgery, and maybe a little longer, 3 hours when we did a bridge to transplant from an LVAD. Explanting the LVAD was a little more, time consuming. I tend to normally, you just cardioplegic the heart, but we cardioplegic it just with a crystalloid solution with a high potassium solution. The whole idea is for ease of explant more than anything else. It takes about another 3 minutes to get, the heart to stop. But if the heart is flaccid, you're able to cut very well and you're very clear. One thing which we believe one should never do is to cut off too much and have not enough tissue to sew up. Because once the heart comes, you need to stitch it back together at the shortest possible time. So we need to have enough cuff of aorta, pulmonary artery, LA cuff, IVC and SVC. The trickier part is sometimes, if the heart is beating, there's a lot of blood coming, you put the cardiotomy sucker, still there is not good vision. Once you cut and take the heart out, you will suddenly find the IVC retracts back. So just to avoid that, I found it is much easier to put a lot of topical cold, a little bit of a hyperkalemic, whatever crystalloid solution, get mechanical silence. That takes about an extra 5 minutes. But, it adds so much to the pleasure of cardiectomy. Do you have anything to add?
Just a couple of questions to you. Do you do the VO2 max, and do you do the cardiopulmonary exercise testing? And what exercise do you ask them to do? Do you make them walk around, or what? Do you have treadmill for that?
We had a VO2 max machine when we first started out our heart failure clinic in 2005. And for many reasons, it didn't work out. And we are now not using a VO2 max. We use the Seattle heart failure model to, plan indications and referral for transplant, which does not require a VO2 max. The Seattle heart failure model is something you can do in the clinic itself. A likelihood of survival in a year. If your survival is 90% and above, it's fine. If it is less than 90%, you're at a high risk and you would like to transplant. But again, there are many programs which use VO2 max. We don't use VO2 max. A surrogate for VO2 max is a 6-minute walk test, which is more relevant in lung transplant, but we tend to use that. We use an ECHOS, 6-minute walk test, NT-proBNP, and a Seattle heart failure scoring. Hi,
Okay,
Venkat.
Dr. Venkat is,
Yeah.
Dr. Venkat is back now.
Okay, so
And,
thank you. I'm sorry, I don't know what happened. So anyway, I think we were on the screen.
you were
So
able to take the heart out.
yeah, okay. So once the heart is explanted, you will have an RA and an LA cuff. So what then I do is to divide having an enough IVC cuff, detach the IVC off from the RA cuff, and same way SVC off, and then excise the remainder of the right atrium. That way you can leave as much as IVC tissue or right atrial tissue along the IVC and the SVC, because you never know when you explant a heart in a heart failure patient, the heart enlarges anteroposteriorly. Except pulmonary artery, every other tube I had to do interposition graft. I have done interposition graft of SVC, I have done IVC interposition graft and aorta. Number of times I have done, because you never know how, even if you cut right up to the level of this above the valve in an aorta in a recipient and the donor heart comes, even if they give you as much as aorta as possible, there'll be a gap because of the anteroposterior elongation. So the bottom line is keep as much as possible. It's easy to trim afterwards rather than struggle. So when the donor graft is then taken out of the eyes, then you just have to prepare on the table. You have to make sure there is no injury, damage surgically, then you have to repair it. If the lung is also explanted, then there will be a cut in the left atrial appendage, which I tend to repair it on the table meticulously. Then we have to look for PFO, because it's important, because these patients have bad right side of the heart. They may develop PVR issue, and then you will have a right to left shunt, and then they will have a problem in the ICU with oxygenation. So you have to make sure that you close the PFO, and then you prepare the aorta and PA, because if the lung was not taken, you may get RA, the PA, both bifurcation. So you have to basically open it and then prepare it, and then prepare the LA cuff. So this is a graft in my hand. It is a beautiful graft, and the patient's heart's explanted, and I'm ready to go on stitching it. So the bicaval technique is what we're going to do. The first stitch starts basically at the junction of the left superior pulmonary vein and the left atrium, where the appendage should be. So that's where you should start from the recipient, outside in, and then you go into the donor or heart, where the left atrial appendage is. The heart is actually upside down, so that you can start the left atrium. Once you've done the few sutures, the heart goes into the pericardium. And then once you have done this layer, then you actually turn the heart 180 degrees, and then you can do the right side half of the atrial cuff. So I'm going to show a video clip. I hope it doesn't freeze. So this is the recipient, the donor graft. I'm just preparing it.
Atrial cuff is completely fashioned.
So I'm putting a forceps through the IVC into SVC.
Atrial septum is carefully inspected.
And then I prepare the SVC. There is no PFO.
SVC is prepared.
And I'm looking at the aorta and the PA, and I'm preparing the PA.
Separated, and the PA is divided.
First suture is the
left atrial cuff anastomosis.
So that's where the junction of the left superior pulmonary vein and
the left atrium,
on the outside in, and then inside out on the
junction of the
left atrial appendage to the aorta, on the left atrium, near the left atrial appendage. So then you lower the heart.
Then the anastomosis is done. And after taking few sutures, the heart is drawn down, and the assistant puts two fingers.
The assistant puts two fingers into the mitral valve and splay it open for you. Then you can see the whole nice edges, and you can stitch it in 12-15 minutes. You can stitch the left atrium. It's a good deep bite, good spacing, and you have to make sure the sutures are laid in correct position.
Both layers were taken on the coronary sinus. Once you reach to the end of the left atrial cuff near the IVC.
So you need to line up the IVC to IVC, make sure the alignment is okay. So once you have come, then the heart is rotated 180 degrees back
the outside,
facing the normal way.
Of the donor heart. Then the heart is actually now rotated 180 degrees, so that now the
aorta is the PA is facing on the right alignment.
Or facing upwards. So now with the assistant pushing the aorta upwards.
So you do the superior part of the roof of the left atrium with the other end of the suture.
Anastomosis is now done, making sure that the alignment of
So at this time, SVC should be correctly aligned. So I think the same problem happened. Oh dear.
cross clamp
So-
is applied and
So at this, once the left atrium is done, I put the sucker through the SVC into the IVC, into the coronary sinus, and then I do the IVC back wall anastomosis.
With the cardioplegia being running,
So with the cardioplegia running, I do the back wall of the IVC.
started with a running
See, you
field
can see that you can still do it
You can
even
see
with the
here,
sucker in place.
as the cardioplegia
This is to reduce the warm
sucker is
ischemic
placed,
time.
Additional sucker is also placed to enable the back wall of the IVC anastomosis.
So this is to do the back wall of the IVC.
Usually take few minutes, and during that time you're already up and running with the back wall of the IVC anastomosis.
So once the back wall is done,
Once you have reached the full back wall,
you
as
can do the
turn
back, you
corner,
can do the
you're
PA
facing
anastomosis.
towards the front wall.
So now the PA,
The IVC anastomosis is stopped. Then the PA anastomosis is
I do the
started.
back
As
wall
you
of the
can see,
PA now.
Pulmonary artery back wall anastomosis is carried.
Stuck again. And then I do the aortic anastomosis. Oh dear. It's it didn't happen before. I don't know whether it's I'm sorry guys. Again.
It's okay, no problem. Take your time. So while you're there, I just got a message that Dr. Anve Mulay is here.
Okay. Hello.
He has got about 150 heart transplant experience. He's from Mumbai. Dr. Anve Mulay, can you hear us? And Dr. Shiva, can you unlock his mic and the speaker?
Yes, yes, I'll do it.
Come into the discussion.
Yeah, sure.
Vaikun. I need to. Can you help me with this?
Dr. Murthy, like, what's his name, like the login name?
Came up. Mulay, M-U-L-A-Y. I think he's not there at the moment.
No, he's not there, I think.
Yeah. Somebody called Neeraj just message, so we can message him, ask him to,
Okay.
That's fine. So, how do you give the cardioplegia, Venkat? I think do you do through direct coronary ostial or?
No, I think he's busy.
It's off mic, I think.
So, what is your sequence of events for this, Dr. Sundar?
Yeah, we are pretty much the same. We do the LA anastomosis, then we do the IVC, and then the pulmonary artery. And we tend to replenish the cardioplegia every 45 minutes or an hour. We give custodial. We cross clamp. The aortic anastomosis is still not done. So we cross clamp the aorta and give root cardioplegia with custodial. Most probably you may need one additional dose of custodial, and that by then you should finish all the anastomosis.
Actually, okay. Murthy, can you hear me?
Yeah, we can hear you now.
So Murthy, basically, we don't give, it's a cold, just St. Thomas's, no custodial. And in fact, most heart transplant, we implant in 35 minutes because we give one dose of cardioplegia after LA. And then that's it. So, and then after LA, we put a separate cross clamp and below it put the DLP to give a root plegia. During that time, a sucker goes through SVC into the coronary sinus to do the back of the IVC. And then you do a back of the PA and then release the clamp, fashion the anastomosis and do the aortic anastomosis and then give a hot shot, release the clamp, and when the heart's beating, you do the anterior wall of the SVC, and then anterior wall of the IVC, anterior wall of the PA, and then SVC is done completely heart beating. So that means our warm ischemic time is really short.
Okay.
So I need to share the video now, yeah?
See if you can.
Can you see the slide?
Yeah, we can see the slides and the slide sorter view.
Oh, okay.
You
are not seeing the main slide.
We're not seeing because you're not gone on the slideshow yet.
Okay.
We are seeing the whole computer screen, what you're doing now.
Hang on. Yeah, I've just done it. Yeah.
Yeah. Now
Has
it's
it done?
changing the full screen now. Yeah.
So I better not cause any more trouble by putting the video back on. So the bicable technique. Now I have to say I have only seen very few of them, and I have not done a single bicable technique. And there's one colleague in my place, he only does bicable. He doesn't change. Outcome is, when he does, it's not different. So we haven't pushed. So it's basically the left atrium. On the right atrium, when I showed you how we explant the heart, the right atrial cuff remains. So you just have to do a second layer of suture. You start from the intraatrial septum, and then you have to go all around the atrium. So in the donor heart, what you have to do is to make an incision from the IVC towards the right atrial appendage, and that gives a new cut. So you basically splay open that into the recipient's atrial cuff. So let's go to the next slide. So that's a bicable technique done. So we have to make sure that the hemostasis is checked. When it's fully warm, we start the inotropes, give a second dose of steroid when the heart is being perfused. Make sure hemoglobin is hemoglobin is 10 plus, base deficit is +2, -2, because we filter the patient during bypass if required, all the abnormalities corrected, and then we try and come off bypass. The biatrial technique I mentioned, two atrial cuffs. So what you have to do is to incise from IVC towards the right atrial appendage. You have to make a cut in the donor heart. So once you have done the left atrium, this goes onto the right atrial cuff of the recipient. So what you have is a very long suture line. So in this technique, if you have to do, you may have to give extra cardioplegia because it's such a long anastomosis, and I don't know whether you can do it off clamp. So special consideration, now previous cardiac surgery and bad explant. Now it is very important to avoid prolonged ischemia, because what we do not want is the heart in an icebox waiting and you are not ready. So that's why, if required, you may have to expose the femoral vessels before stenotomy. And then you have to do a redo stenotomy and do all the dissection before giving heparin. We normally put a membrane behind the sternum if we are doing the bad, so that when the sternotomy saw wouldn't go and damage the outflow graft of the LVAD. And in complex transplants, we probably have 2 consultants just to help each other, really. Congenital heart disease. Now, complex multiple previous surgery is a problem. In the UK, most of it is done by the grown-up congenital surgeon with a Gooch specialty. Especially if a patient had an atrial baffle, mustard senning for a TGA, then you have to be cannulating. You have to cannulate very high in the K-way, because if you go from the atrium, your cannula won't go in because of the baffles. Patients with the persistent left SVC, you may have to, that is a surgical challenge. You have to cannulate separately, and you may need a long innominate vein from the donor heart to reconstruct it. Or you may have to do, there are a number of techniques available if a patient has got a left SVC. We haven't done one transplant like that, but we know how to plan for it, but it is complex. And same way, patients who have left SVC, you may have to retrieve the heart with the innominate vein, so that you have a very long SVC venous system, so that you can reconstruct the left SVC back into the innominate vein of the donor heart. The heterotopic transplant, now I haven't seen one, but the aim is to keep the patient's own heart and put the new heart into the right chest. So you basically do a left atrial anastomosis, aorta goes on to end-to-side to the aorta, end-to-side onto the PA, and then the SVC is anastomosed onto the I think through the SVC, so that the half of the venous blood comes into the donor heart, and then somehow the venous blood from the body goes into the recipient's own heart. So both work simultaneously together. Domino heart transplant, that is an interesting concept where if a patient needs a lung transplant, you do a heart-lung on that patient to make the technique easy, but their good heart can be retrieved and used to another recipient who need the heart. Now, this was done predominantly in Cambridge, where when the lung transplant outcome used to be bad, where the where the airway anastomosis was a problem, they tend to do more of a heart-lung and give the heart of the double lung recipient into another heart patient. But nowadays, it's very rare, but we still get 1 or 2 domino heart transplant a year in the UK. Now, once the hemostasis is secured, chest is closed, patient goes out with a continuous cardiac output monitoring, inotropic support with inhaled nitric oxide. We normally use milrinone and noradrenaline with dopamine. If needed, then only we start adrenaline and put a balloon pump. If a heart struggles with milrinone and the adrenaline, 0.06 mics of adrenaline, and the cardiac index is borderline, we go straight into ECMO support. The options are to cannulate the groin with a femoral venous drainage, and we can either put a graft in the axillary artery, or if the patient is, if it's going to be a short period, we just tunnel the arterial pipe below the costal margin and put a couple of snuggers and directly cannulate the aorta and then close and then bring the patient out. And then the problem is you have to reopen the chest to decannulate the patient. So if everything looks reasonably good, we could close the chest, means we could put a graft on the axillary artery, 8mm graft, and then close the chest so that you can even wake the patient. With the patient sitting up, awake, extubated, we can wean the ECMO. We just tie the graft in the axillary artery and pull the groin venous pipe. And that's how we use the ECMO support. And the immunosuppression is an RATG. We give 1 to 1.5 milligram per kilogram for the patient. And we normally give 3 doses. Sometimes we prolong, we give a delayed calcineurin inhibitor starting if a patient's got a borderline kidneys to avoid jeopardizing any renal function. So we might give 1.5 milligram day 1, and then we give 1 milligram on day 2, and then we may give a break of RATG for a day, and then we give 0.75, and then a break, and then give another 0.75, but we'll start a cell cycle inhibitor once the RATG is finished, but we might delay the CNI introduction even as high as 5-6 days. But we keep, during that time, we keep them on IV methylprednisolone. So initially we give 500 milligram before we start, 500 milligram as the heart is reperfused, and then we give 125 milligram, 3 doses 8-hourly, and then we give we give 1 milligram per kilogram in 2 divided doses, but then slowly reduce. So 1 milligram per kilogram. So in a 70 kilo patient, we give 35 methylpred BD, but then the next day we'll make 35 and 30, then next day 30 and 30. So slowly we reduce so that at the end of it, they would be on 15 milligram of prednisolone a day, which means 0.2 milligram per kilogram. So RATG is our induction therapy. So our practice now in Manchester is tacrolimus and MMF with prednisolone is our drug of choice. Sometimes we give cyclosporin, especially if a patient is not extubated, not taking orally, absorption is an issue with TAC. So we give IV cyclosporin, but our preferred is TAC and MMF is our combination. And we look at renal function, on the white cell count, and we always give ganciclovir if it is a mismatch from the CMV, whether it is a reverse mismatch or a real mismatch. which is donor positive, recipient negative, or recipient positive, donor negative, that we give IV ganciclovir. If both are positive, we give acyclovir. And then as soon as they are able to take orally, we give them valganciclovir. And we look at really CMV log scale very actively. If a patient has not received, or even those who are on Valgan, to make sure they don't get active CMV infection. If the log values of CMV, say log values goes higher up, we immediately start them on higher dose of Valgan to avoid any CMV infection. Because we know when they develop CMV infection, they are more prone for rejection. So we do protocol biopsy. We do weekly biopsy in the first month. First biopsy is usually after second week after surgery. And then we do every week for the first 2 or 3 biopsies. And then we go to 2 in a weekly. And then monthly from 4 to 9 months. And then 2 monthly biopsy during the first year. And then go to 6 monthly. So around 18 to 20 biopsy in the first year. But after 18 months, 2 years, we won't do it unless required. But all patients get a 6 monthly MOT test, which is basically they come, bloods, ECG, echo. We do not do routine coronary angiogram, but we do CT coronary angiogram, and we use a cardiac MR scan because we have a very good MR imaging department. We use CMR scan. And any rejection, if a patient's got in a grade 1R, we repeat another biopsy. But if they have grade 2R, we will bring them in and we give them increased dose of methylprednisolone, 3 doses, and then we increase their oral steroids, and then we repeat a biopsy in a few weeks down the line. If someone's having repeated by grade 2R rejection, that's a problem. We might move them from tacrolimus to maybe cyclosporin. If they are on cyclosporin, we move them to tacrolimus and see what happens. If they continues to have a rejection, then we may have to add cyclophosphamide. Sometimes we give methotrexate. And now comes is the antibody-mediated rejection, AMR. So we do look for AMR. We do the C4D staining. If a patient's got an AMR, we look at the the antibody levels, DSA assays, the donor-specific antibodies. If the DSA is high, we have to do plasmapheresis, and we do plasmapheresis for our patients. So again, it is having all those available to treat patients. So I think that's what the first talk is. So if there's any questions, we can answer.
Yeah, thank you, Dr. Venkat. Dr. Sundar, can we have your comments?
Yeah. Venkat is offline, is he?
No.
My video, okay, it's back. Yeah.
Yes, you're back on. Hi, Venkat. This is Sundar here. We met in Taj Hotel when you came and gave a wonderful talk on ILVAG. Now that goes back many years now, probably about a decade, I think.
Yes. Yeah.
Yes. And one point of connect was I hold Chengalpet Medical College very close to my heart because I did my senior house surgery in Chengalpet.
Did you?
I was pleased to know you're from Chengalpet. Chagaramurthy, you're in Chengalpet,
Coimbatore.
You're in Chengalpet. Oh, Coimbatore. Okay. All right. Yeah. So pretty much the same, we've been following this. In fact, when we came to India and started the program, we started with the same rigorous induction protocol, but we found that our patients had major problems of infection. The problems that we countered were more of infection rather than rejection because we worked them up so well. We get the PRA, we try and avoid, at least in the beginning of our program, we took really straightforward cases, no sensitized individuals. The first case we used the rat gene. And then it was a heart lung transplant in 2007, absolutely fine. Day 5, he was sat up well in bed eating when he started having a little bit of a sore throat, a cough, desaturated, white out lung, intubated, died by the evening. All in a matter of 12 hours. We then our protocol, we stopped that, and we used the protocol of Papworth, where they give 2 grams of mycophenolate in the ward before shifting to theatre.
Yeah.
And then the triple therapy. And
One gram, we give the same.
You're right. 2 tablets. You're right. 1 gram, and the rest is the same. You give triple therapy, and we try and scale down on the Solumedrol as quickly as is possible. Now, with this, we found that we've been able to manage, and so we don't do much of an induction, except in the case of lung transplant, we use Bezilicimab, IL-2 receptor antagonist. Barring that, it seems pretty much the same. The problems of infection are much more of a challenge in India at this point in time, which we have surpassed. The techniques are pretty much the same, except I do the heart transplant in a single aortic cross clamp. The question of, is an extra 20 minutes more. So we believe that having given custodial, we can, and we haven't had any problems so far. It's a quiet, still field, operating field. You place your sutures well and all those things. But again, there are a million ways of skinning a cat, and what works best for you is what you do. Do you use DCDs, Venkat?
Pardon?
DCDs.
Yeah, DCD, yes. I was the 4th center in the world to do heart DCD was Manchester. I did this in 2015. So we have done now 11 DCD heart transplants. We have been to
Fantastic.
13 or 14 DCD retrieval. But I will say DCD retrieval is a really technical challenge, because you have a patient who had cardiac arrest, and then everything is rush. It's when you open the chest, the heart is fully distended. You have to drain the blood into the OCS machine. But it's most of the ones you have done in a matter of 26 minutes from the time of cardiac arrest. The heart was in the OCS and started beating, and was able to transplant them. So we published our first 6 or 7 in the European Journal Cardiothoracic Surgery to say how to start a DCD heart program. So that's sort of because by then, Papworth had already done 40 or 50 DCD heart transplants. So for us, it's mainly the cost. But luckily, the Department of Health is basically funding the DCD, the OCS, TransMedics OCS machine and consumable for DCD program. So we've got 5 kits available, but that's
Did
only.
that really ease off on your recipient list pressure? Did that really go a long way, or there wasn't much of a difference?
So if I look at not last financial year, the year before last, we did 6 DCD heart transplant and 16 DBD heart. So it almost like a third of our number were from the DCD. So it will definitely, because these hearts are going to be binned otherwise if you don't use them. But at the moment, we cannot do them without a TransMedics technology, because there is no other machine available on the market. And the TransMedics has now increased the price of their consumables to 40,000 pounds. We bought it for 25,000. So I remember when we bought, the machine was given free, which is 100,000 pounds, which is 1 lakh pound. That was the machine cost, but they gave the machine free if we buy 5 consumable every year. And the consumable was 25,000. But now they've increased it, because now they have got, they know it that it's a DCD. So the government is funding. But if we have a good platform, which Cambridge is actually developing, but I don't know when it will be available, but they are trying to develop a working mode, because DC, the TransMedics is a non-working mode. It's just a perfused beating heart, non-working heart. But if you can actually make a heart to work, and then you show that it's actually functioning better, then it may be, but definitely, we still, at the moment, our perfusionists are so busy looking after our VV ECMOs in due to COVID, ECMO crisis. So the DCD is currently on hold, but hopefully, yeah, hopefully we'll
Thanks,
start.
Venkat. One last question before I sign off. Murthy, I have to sign off due to a prior commitment. I had told Shiva. So if you don't mind me, it's
Don't worry. In fact, if we can finish up with this talk, we can discuss more.
No. I'm sure you'll have a lot of questions. Shiva will have questions from the audience. It's a shame I can't stay on till the end. But one question: how many transplants have you been doing in this COVID era? Let's say from March till now.
So it's a very good question. In fact, I gave a webinar for one of the do you know about the Paragonix Sherpa box? It's a new type of transport box. Anyway, so I gave a webinar for them. It's about the heart transplant during COVID pandemic. Now in the UK, we did not do any for the 2-week period in end of March, but starting from April, even the donor numbers dramatically reduced. But in the last 2 weeks, there were 4 heart transplants were done in the UK. In Manchester, we did 2 during the COVID crisis. Both are urgent recipients. So what we did was temporarily we halted that program. And we said that we will only transplant recipients who are on inotropes in hospital who have no other option. So there was a patient. And then the elective we thought that anyone on a VAD, long-term VAD, who are stable, we shouldn't transplant them at this period of time. So 2 patients we transplanted, both were on inotropes in hospital. So I know that Cambridge did 1, Harefield did 1, and I think this week Birmingham has done 1. So I think the heart transplant numbers have started to come up, but lung transplant.
They've all done well. They've all done well.
They've all done well. Heart, not a problem. Lung is a problem. It's a huge, because the whole issue is the lung. So that's where the problem. Yeah.
Great. It was great speaking to you, Venkat. I will connect with you later on something else. I'll get your email from Tyagaraja Murthy and I will connect with you. Okay? Thanks, Shiva.
Thank you. Thank you.
Venkat, one of your previous residents, Dr. Neeraj Kamath,
Yes.
he's online actually.
Okay.
And he's now currently working with Dr. Muley.
That's correct.
Another question from one Dr. Prakash. Is cardiac MRI better instead of endomyocardial biopsy to diagnose rejection?
It's a very, very good point. I think that's a part of a study and trial, which, we are in the process of looking at it. And one of our, because we have a very good CMR department, we've got 3 CMR scans, and one is specifically designed only for research. It's funded by British Heart Foundation and other charities. So at the moment, we do not have any data to prove CMR scan is better. So maybe in the future, we will know. But at the moment, we unfortunately do not have, evidence or any correct sort of protocol, how frequently you have to do, what you look for rejection, and how, what is rejection and how do you treat. So it is probably, we will come to know in future, I think, but at the moment we still rely on biopsy, fortunately.
Dr. Neeraj, you've got a question, you can ask it.
Yeah. Hello, Mr. Venkat. Nice to talk to you. Nice talk.
Hello. Hi, Neeraj. How are you?
Missing all the fun?
Yeah, it is. Yeah, missing the fun. Yeah.
Just wanted to know more about PGD in your experience post-heart transplant. I know the ways we have managed it for the last 2-3 years I have spent with you, but your last 10-15 years of experience would like us know better about PGD.
So PGD is a devastating complication, which mild PGD where a patient needs a bit of support, or longer term inotrope, or a patient who needs balloon pump. That is, that's okay, that we can manage. But if a patient struggles to come off bypass, then you are basically on your knees. Everybody is looking at you, isn't it? everyone in the theater is looking at you. Even the anesthetist looks at you and say, "What have you done?" Okay. So I think that's a devastating complication, and that's where you need ECMO. Our preference is Centrimag because I know the ECMO kit you have in India is the Mackay Cardio Help kit, but we use in the UK predominantly Centrimag, which is basically a very good centrifugal pump. We add an oxygenator onto it, and it's versatile, and you can connect peripheral, central. If it's the easiest way to do is to put a pipe in the RA, pipe in the aorta, and basically tunnel both the pipes like it chest drains, so that you can close the chest and you can even wake the patient up. But in order to explant the ECMO, you need to reopen the chest. That's the problem. So initially we always used to do central, and we have to reopen. So they tend to bleed more because the purse strings, however good they are, they will slowly ooze around the aortic pipe. The blood pressure goes up and down, and so then the infection complication will increase. So because of that, we found a way to see, can we try peripheral. So if a patient has a axillary artery, expose them, and the groin venous pipe. So venous drainage through the groin pipe, through the Centrimag, through the oxygenator, return 8 millimeter graft into the axillary artery. Then you can close the chest. You can wake the patient up, sit the patient up. Then it makes it probably easier to weaning the, even weaning the ECMO is better. So what we notice that, we've got a data on our last 280 heart transplants in the last 12-year period. I think the incidence of PGD requiring ECMO is around 20%, 23%, I think. But the problem is they consume a lot of resource. The mortality is slightly higher. Their 1-year survival is also inferior. So what we find, the only parameter which differs is the bad explants. So those who have bad explant is the only predictive, significant difference between the non-ECMO group, ECMO group. The donor age, recipient age, size matching, mismatching, CMV, ischemic times, none of things matter. It's the only thing matter is so that's what we found. So again, it's a devastating complication, but you do need to know how to manage. Otherwise, you have a patient dead on the table, really, or within.
Thank you, Dr. Murthy. Thank you.
One more question on Dr. Prakash Ludhani.
Yeah.
So he wants to know regarding the metabolism of tacrolimus. Preoperatively do a genotype study with CYP3A.
No, I don't know. We don't do any of those things. No, we don't. So, okay, the reason why, the tacrolimus is very diabetogenic. So what we found, because when you look at the trials, TAC and MMF has shown superior to cyclosporin MMF combination. But cyclosporin is a very good drug, even if a patient has got, because it gets absorbed higher up in the stomach. So, and it's available in the IV formation. So it is, if a patient is unable to take orally in the early stages, you can give. But tacrolimus, my understanding, is quite diabetogenic. So in a patient is already type 2 diabetic and the blood sugars are high, and you are unable to control, infection risk is high, then then cyclosporin is better. But our preferred combination is TAC and MMF with steroids. But we don't do any studies like, which is better, this and that. No, we don't.
Yeah, Prakash, you want to know about cardiac MRI instead of...
No, I did say we don't use cardiac. It is a study. We will know in the time, but at the moment we don't have an evidence that CMR is better than endomyocardial biopsy. We don't have the data. Yeah.
In your experience of these 280 patients, what is their 1 year, 2 year, and 5 year survival?
So
quality of life.
So how? There's no doubt. When the patient go home, I have patients going back to normal life. They have, especially if it's a male patient, they can have children, because it's their wife is going to carry the baby, isn't it? Even if they are on immunosuppression, doesn't matter. I've had a number of my recipients have had children after transplant. So the 1 year survival is currently around 80% in Manchester, and Papworth probably has close to 90%. So that means if a patient survives the operation, the chances of them living 30 days is like close to 90%. And if they make it to 30 days, they go home. Between 80, 90%, they live 1 year. Those who survive the first year, their median survival is around 12 to 14 years. So that means those who survive, they tend to do well. But you need a very good cardiology side to look after, because I don't look after them, because I don't see them in clinic, because it's not my job. I don't know how to manage. It's all those things like managing their kidneys, managing the CMV. We don't see our patients coming in with CMV reactivation. They develop CMV, pseudomembranous colitis. They don't come in with infection. We don't roger their kidney with a lot of calcineurin inhibitors. So, we need to reduce their dosage of steroids, or even sometimes we don't get them CNI free, but we can reduce their steroids to very low level and a very small dose of cyclosporine. So all those things, we need cardiologists to look after them. And so I would say in Manchester, our 5-year survival, our 10-year survival is probably around in excess of 50%. Yeah.
I keep seeing you on the Manchester news and other things. And people, poster boy of North. That's
Yeah.
great.
So somebody's asked Cytosorb. Yeah, Cytosorb. Do you use Cytosorb? Yes. I think what we have done is we are using Cytosorb for all complex VAD explants, BIVAD, Centrimac BIVADs going for transplant, or a patient who's got a VAD with a driveline infection. Because as soon as you go on bypass, they become completely vasoparetic, and they're on noradrenaline, and then before you know, we need methylene blue because this blood pressure is like 30 or 40. So those sort of patient, Cytosorb, I think, is beneficial. We have Cytosorb, but it is not studied, licensed. It means there is no trial to prove Cytosorb in those patients is beneficial. There is a trial which is planned by Harefield with all 6 and all the 5 centers in UK are going to participate, where we are going to do a trial to do a randomize between Cytosorb or not using Cytosorb in these patients. But for a routine transplant, probably not needed.
I think Ganapathy Subramaniam, who's a pediatric cardiac surgeon from Apollo Hospital.
No, I'm with
No,
Dr.
with
Bala.
Dr. Bala at
Hello.
MGM.
Bala,
Hello.
you've got a question.
Hi. Yeah, see, you said post-VAD, they are a sort of high-risk group when you do transplant on them. So when a person is carrying on well with his VAD, how do you decide whether to go ahead and transplant
Very
them or
good
not?
question. Okay, so this is $1 million question. It's a very good question you've asked. Now, should a stable LVAD patient be transplanted? Now, that is a question. Even in the International Society of Heart and Lung Transplant, we are asking the same question. Should we transplant a stable LVAD patient, especially in the current HeartMate 3, which is an exceptionally good pump? There is no pump thrombosis, but the bleeding complication still remains. The thromboembolic complication still remains, but the stroke seen in HeartMate 3 is much less than the HeartMate 2 and HVAD. So the question is valid. So I think what we have to do is to make sure we don't list them within the first year, because it takes 3 to 6 months for them to recover from the operation and start getting the benefit of the VAD, start enjoying it. So I have this philosophy. It's called honeymoon theory. It's called a honeymoon. When a patient you put a VAD, the first year is honeymoon for them, because they are in such a dreadful heart failure. Even going upstairs to his bedroom or going to the areas of the house he has never been, he feels great, because this previously taken for granted. But once a year crosses, then they start to feel the tethered feeling. Oh, I have to get rid of this. I don't like it. I want to have a bath. I want to sit in my bathtub. I cannot do it. I want to go into a swimming pool. They don't like, long distance travel is a problem. So there are two groups. One group is very happy with that. They learn to live with it. Now I've got patients whom I did HeartMate 2 in 2011 and 12. They are still alive, and they are doing so well. They go on holiday to various European places. They go on cycling trip. But but those patients, some patients, they develop complication, especially those who develop driveline. So to answer your question, I do not know, should a stable LVAD patient be transplanted? Now, even in the US, previously, when a patient gets a long-term VAD, they had 3-month supra-urgent status, so that they put a VAD and they transplant them in 3 months.
Correct.
That's a waste of money. So now that
Yeah.
is gone. In the US, that system has been changed from this year, that a patient has a stable, when a patient gets a long-term VAD, they do not get the priority. So they only do urgent transplant for patient on temporary support, like ECMO and Centrimag ECMO, Centrimag LVAD, Centrimag BiVAD, or a Impella, or inotrope, or a balloon pump, like in UK. So to answer your question, I don't know the answer yet, but I would say if a patient is doing very well, they
Then
should
don't touch them
probably on an elective transplant waiting list. And if they get a very good offer, we should have a discussion with them. But we normally don't put them on the list for 6 to 9 months from the VAD operation. But we do put them on so that if they develop a VAD complication, they have to be on the list to make them higher urgent category. So that's what we do. So if I look at I've got 38, 40, 52 patients on our waiting list. We've got 40 odd or 38, 40 patients are VAD patients on the waiting list. So most of our waiting list is VAD
It's
patients.
bad. Yeah.
Yeah,
So if
yeah.
they have driveline infection, does it affect the outcome?
No, we tend to do lot of local procedure. We only
Yeah.
go to transplant if we have done, we have done exploration, back pump therapy, this and that. And if it becomes a systemic sepsis, once it develops bacteremia, and then you stop antibiotic, and if the VAD is colonized because it's a metal, if you stop antibiotic and they become ill again, then the only solution is to take the VAD out. So those sort of patient, then transplant is the only option. If a patient has a localized driveline infection and after multiple procedures, you have no other way left, then transplant is the only operation.
No,
These
do they?
patients are sicker. Yeah,
Okay.
they tend to behave like a septic endocarditis
Okay.
patient. Like, go on bypass, they become vasoparetic, and they become, you take the VAD out, you put the new heart. New heart is working happy, but it struggles because they are in a high cardiac output state. Their temperature, they are 38 degree on when you come off bypass. You may have to cool them. So we end up going out on ECMO for a few days for the situation to improve. So I think, that's what we found, that those who have a VAD explant, they end up with a higher rate of ECMO than non-VAD patient. Yeah.
Thanks.
Dr. Mankit, there are two questions from the participants. One is, what is the longest survival from your center or in UK?
Yeah, in my center, I have a 29-year-old, 29 years post-transplant.
Oh, fantastic.
Yeah. So, he was probably done one of the very earliest days. My first heart transplant that I did, he's 10-year post-transplant. He's now, he has 2 daughters.
Okay.
He plays volleyball. He's a bank manager, I think. He plays, because we have an annual transplant games in the UK every year.
Okay.
All the transplant patients participate in a transplant games. So we have a team, Withenshaw team, where the heart and lung patients. So he does, volleyball, this and that. So, we've got some excellent patients. And We have our, I did a heart lung for Eisenmenger. She's alive. Severe pulmonary hypertension. So yes, we have good stories. We've also,
Okay.
I'm not saying that we don't have mortality, but it's more of a good story than bad outcomes. Yeah.
Okay. Has any of your female recipients become pregnant?
No, that is very difficult. No, we tell them not to. They will get, they'll probably get this long-term depot injection contraception. But so we advise them. They, they can't. They shouldn't. Yeah. Because so bad patient. No, we haven't even for the bad patient. No, but we did a postpartum DCM. I did a VAD. Within a year, the heart recovered. I took the VAD out because the heart completely recovered, and we told her not to get pregnant, and she got pregnant. And then we had to bring her in, very closely watch her, and then she had an elective cesarean section, 36 weeks, and we snipped the tubes at the same time so that she doesn't come back. But no, we haven't had any post-transplant patients having,
Prakash, you had...
Yeah. Hi, Dr. Venkat. It was nice to listen to your talk. I have a couple of questions. This is regarding the ex vivo and the DCD heart, because I've been trained at the center at St. Vincent's, Sydney with Umut et al. So I have a few questions for you. What's your choice of solution? Is a cellular or acellular perfusion when you do an ex vivo lung perfusion? For ex vivo?
For the lung?
Yeah, for the lung. What is the choice? Whether you use a cellular or acellular perfusion?
Good. Okay, so EVLP, ex vivo lung perfusion, for the first center to do it in the UK was Manchester, but once the developed UK trial stopped, we unfortunately have not done any EVLPs because if you look at what EVLP has not been universally, it's not taken off very big time in the rest of the world, apart from Toronto and few centers in Europe, because EVLP is a very labor intensive because you retrieve the lung on an ice box, come in, and then you need to open on a theater. You have to put the lung back in, and then you have to rewarm it, and then you have to trial it, and then have to cool it back. And so I think we found that, it was so tiresome. As a surgeon, if I have to do EVLP, and then 6-8 hours later, then I have to do a double lung transplant. It was just not on. So when we started with the acellular solution, but we went back to the Stickstein's cellular solution we did a Vivaline machine. So that's what we used at that time. So we have the O negative or a cross match to the recipient's blood group. So that's what we used. But for the ex vivo heart, it's obviously the donor's own blood. Yeah. So the DC, we drain the blood, and then we take our cell saver, and then as soon as you open, so two surgeons, so one slashes the incision, other one does a stenotomy, retractor, open the left pleura, clamp the thoracic aorta, and then the first thing you do is to heparin into the RA and PA, and then put the cannula in the RA, heart is distended, and then head down, drain as much as blood into the collection bag, and then you put a DLP, cross clamp, quadriplegia, and then take the heart out as quickly as possible, and then perfuse it on the OCS. I was going to give the talk, but it's too late now. Probably it's, we'll probably miss it for some other time. Yeah. So that's what we do. So for using the transmedics OCS. Yeah. If you are in St. Vincent, you might have seen a few of those retrievals. Yeah, absolutely.
Yeah. I was a part of 20 DCD hearts.
Fantastic.
Yeah, so that was my. I have one question. If in a patient who's got an idiopathic pulmonary arterial hypertension, he requires, his RV is dysfunction. We know basis on all the literature, whatever he says, that RV will remodel and everything. I just want to know clinically that when this sort of patients will need, what is the clinical thing you feel that this patient will benefit from heart and lung, not from lung?
It's a very good question. Very good question.
I just want to know.
So good question. So what I would say, if a patient with this IPAH If they are in sinus rhythm, if they are still in sinus rhythm, even if there is evidence of right heart failure, and if the PA is generating, the RV is generating a pressure of 70, 80, 100 systolic, it will be a real post-operative storm looking after them. They will definitely need ECMO. We will, most of the time, we will come out on a VA ECMO support if we're doing double lung transplant on them. But if they are already in atrial fibrillation, then it is one of, and it's permanently in AF, I suppose the risk is too high because you may not get them back into sinus, and then it will be very difficult getting them through. And then you probably need a heart lung. There's another problem I also find is not only RV, is the LV. Because in these patients, their left ventricle is untrained. Because not much blood is going through this pulmonary hypertension, only small amount is coming. As soon as you put the new lungs in, this RV is pumping very high amount and the LV fails and they go into pulmonary edema. They behave like an acute mitral regurgitation. As soon as you wake them up, they develop pulmonary edema, compliance goes down, and you have to sedate them back in, then lungs get better. So we've got a number of patients like that. We had to do a tracheostomy, prolonged weaning. But I have to say, even in some young patients whom we thought only option is heart lung, we have done a number of double lungs on the pulmonary, because we have a dedicated pulmonary hypertension unit for the northwest of England, and we get a lot of referrals, and I think we might have done over 20 PH patients in the last 2 years, double lung. Last year we did 31 lung transplants. So that's I think in those patients. But if you are in a permanent AF, lot of liver congestion, big peripedal edema to start with, then you are asking for trouble doing double lung. So probably heart lung for them. Yeah.
Is there any role of cardiac MRI in these patients? Where please,
if you it's a good question, but if you find the cardiac MR scan showing a lot of RV fibrosis, interventricular fibrosis, and lots of then it may help you to say this RV is not going to get better. But most of the evidences, published evidence, say that if in a PH patient, double lung RV does remodel, but it takes time. We sometimes you have to keep them on ECMO for 2 weeks or so, and then they may need a tracheostomy support, sildenafil to help them for some time. But we don't routinely ask for CMR scan, but we look at echo, how good, is RV still generating pressure, and then right heart catheter, and then sinus rhythm, the evidence of how bad the right heart failure is. These are all the things we look at it.
Just want to add on that in Sydney, we used to put all this idiopathic pulmonary arterial hypertension after bilateral lung transplant for 72 hours on ECMO electively. We used to, that is to train the LV. That is what exactly you said.
Yeah.
One more, my last question, sorry. A patient who is on a waiting list of bilateral lung transplant and he has got a coronary artery disease, what would be your...
So, what we have done is, good question again, well done, good question. So, in general, we do not want to take on a multi-vessel coronary disease and double lung, because double lung itself is a very big operation. And then the 1 year survival is what, 80%, and the 5 year survival is 50%. So even with Manchester has a superior 1 year survival to in the best in the UK is Manchester at the moment. We have not lost a single lung transplant patient. Lost 97 lungs, we have lost 1 30-day mortality. So that is our outcome. So despite that, we don't, because to do 3 bypass grafts, it's just too much. So our cutoff is, if somebody has a single isolated disease, and if you want, if it's a single big plaque in the proximal LAD, or a big disease in the circ, or a big RCA with a proximal RCA disease, then we will accept them and we will put the graft. Now, when we do lung transplant and the patient needs graft, we do median sternotomy approach because it makes it easy. Because doing a clamshell, it's just cumbersome. It's good for lung, but to lift the heart and all, or it's difficult. So, I have done what I do is median sternotomy. We do all our lung transplant on an ECMO, VA ECMO. So what I do is I put the patient on VA ECMO, I explant the lung, I implant the lung, perfuse the lung, and everything is happy. We have a very custom-made circuit. Our perfusionist has organized that. It is actually a bypass circuit. So if suddenly something happens, they just have to move the clamps. It turns into a bypass circuit, and I need to give heparin like bypass. So at the end of my implant, I just give therapeutic heparin, or rather like to go on bypass, full heparin, go on, and then cross clamp, and I just do a graft and then release the clamp while rewarming, put the top end done. So if a patient needs, we have done Lima. That's why median sternotomy. If it's a lady, the other I've done OM, I've done right. But if anyone has more than one vessel disease, we say to them, not a candidate. So we don't stent them because cardiologists would say, why do you put a stent if they are asymptomatic? But if somebody has a symptomatic coronary artery disease and they have had an LAD stent or an RCA stent, we don't list them until the dual antiplatelet therapy stops. And when they can stop both the ticagrelor, they can stay on aspirin, it's okay. But we don't want them on dual antiplatelet and lung transplant. It's just asking for trouble.
You're looking for a window period of, sir, for 60 to 90 days? They're off the list of
whatever the cardiologist says, yeah.
Yeah.
Dr. Murthy, shall we conclude with Ganapathi's?
We had in 1.5 hours or more.
Yes.
He must be exhausted, yeah.
I think you're
I
getting
know. Thonda valigudhu bus.
Last question. Venkat sir, take that.
Yeah.
What was the patients with overt RV failure who come with ascites and pedal edema? How has been your heart transplant results?
That's if a patient, we never take the patient. If you take a patient in an overt heart failure to heart transplant, outcomes bad. They don't do that well. We tend not to. We tend to optimize them as well as possible. But luckily in the UK, we don't see that extreme. Because I have not seen somebody coming that bad. But if someone comes with a bad heart failure, we tend to put them on a Centrimag BiVAD, optimize them, and 6 to 8 weeks. We walk the patients on Centrimag BiVAD. We change the circuit every 30 days, keep the cannula in place. And then when they are ready, eating well, walking, exercising, lungs are good, then we can go and transplant them. But we haven't done BiVAD, we haven't done a total artificial heart. I don't think putting 2 implantable LVADs, especially 2 HeartWares or 2 HeartMate3s. I don't use HeartWare, only HeartMate3. I've done over 70 HeartMate3s. So again, these devices are developed for left side. So I think these are difficult patients, I have to say, yeah.
Thanks.
Yeah.
Okay, I think Shiva, we'll wind up.
Yeah.
Sure. Thank you once again, Venkat. So it's a great pleasure.
Okay.
Great interaction, and we'll have another meeting sometime where we can have
Absolutely. I'm okay. I'm glad it was helpful. Yeah. Okay.
Yeah.
Thanks.
Good.
Thanks a lot.
Thank you.
Thank you. Thank you, mate.
Okay, mate. Bye.
Bye.
Hi, Ganapati.
Yeah, Raj.
Ganapati?
Rajesh, can I hear?
Yeah.
Yeah.
Yeah, sure. Nice.
So Wednesday we'll have this coronary angiogram we were discussing.
Yeah, sure. TRM.
Interpretation of
TRM.
coronary.
TRM. Okay.
Okay, thank you, Rajesh. Bye-bye. Good night.